Hello, everyone. Thank you for joining our webinar today. Welcome to the Ontario Caregiver Organization's webinar series. These webinars bring together caregivers and subject matter experts to explore topics of interest to caregivers. And we do this to support and engage chosen family, friends, and neighbors, anyone who's caring for someone else. My name is Katie Muirhead. My pronouns are she, her, and I'm going to be your moderator for today. We begin this gathering by acknowledging the Indigenous people of all the lands that we're on today. While we meet on a virtual platform with people joining us from across the province, I'd like to take a moment to acknowledge the importance of the land which we each call home. The land I'm standing on today is the traditional territory of the Haudenosaunee and Anishinaabe peoples, many of whom continue to live and work here today. This territory is covered by the Upper Canada Treaties and is within the land protected by the Dish with One Spoon Wampum Agreement. Today, this gathering place is home to many First Nations, Métis, and Inuit peoples, and acknowledging this reminds us that our great standard of living is directly related to the resources and friendships of Indigenous people. As an organization, we are learning about the lands from which we work, exploring how we can be meaningful allies and how we can support the recommendations from the Truth and Reconciliation Commission. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our understanding of local Indigenous peoples and their cultures. We invite you to take a moment to reflect on the land where you are. And if you're not familiar with that, we will be sharing an interactive map that tells you which traditional territory your city or town sits on. And you can find that at native-land.ca. Our webinar today is called Quality Standards for Delirium Care. How can I help? In partnership with Ontario Health, this webinar provides an overview of delirium and how family members and caregivers can support people with or at risk for delirium. You'll learn how to prevent delirium, how to recognize the signs and symptoms of delirium, and ways to support your family members' care. I'd like to begin by inviting some of our caregiver advisory panel members to share their personal stories with delirium. And first, I would love to introduce you to Angela Golding. So Angela, if you want to turn on your video and unmute yourself. Angela has lived experience. She's lived the impact of delirium for many years while caring for her mother. Go ahead, Angela.
Hello, and thank you so much for having me on today to share my story. It is truly an honor to be able to do this. I was a caregiver for my mom and my sister. They both lived with me until my mom passed on June 4th, and my sister June 4th, 2016, and my sister on April 4, 2017. I serve now by sharing the OCO webinar information to friends, neighbors who are currently caregivers of parents and family members. And being a caregiver in the past has helped me to do so as an encourager. I'm here as a member of the OCO Caregiver Advisory Panel, where I learn about the Delirium Quality Standard and Patient Guide developed by Ontario Health. My mother was diagnosed as a diabetic after experiencing delirium. She was losing weight, sweating, and fainting excessively. The delirium was enhanced by the open door hospital policy, where she felt that someone was always taking her food and personal item, and she was very uncomfortable. She was not able to feed herself, and that was definitely an issue. Mom had several emergency hospital visit thereafter with delirium episodes. She had pre-existing conditions, high blood pressure, high cholesterol. I spent my before and after work at her bedside to give her comfort, making sure she ate breakfast, dinner, and a snack at night while in the hospital. While at home, my mom called the police several number of times that people were breaking in her home in her state of delirium. After we had moved to her current address, she felt that was not her home and she did not want to live there. So one day she slipped out, took the bus, attempting to get back to where we previously lived. unknowingly to my sister. But she took the bus going in the wrong direction, the route, as she was in a state of delirium. Thankfully, the bus driver recognized at the end of the route that she was in a state of delirium, kept her on the bus, and contacted the police. In the meantime, we were searching for her, and we received a call that she had been found. My mom was thankfully wearing an ID bracelet, and that was our saving grace. So I just want to say that having an ID bracelet for your family is very important. We had that bracelet for her because she had diabetic at that time when we got it. So it was really a helpful thing. And they're critical with every illness, such as. I recognized that there was more going on with my mom because she started to have frequent UTIs, not drinking, eating, and swallowing issues, not sleeping, rearranging her room, and roaming. It was confirmed after a few brain scans and other tests that she had early onset of dementia. Her roaming intensified. She fell and broke her hip and had a lengthy stay in the hospital, which was such a great strain on her health holistically, as her issue of delirium in a new environment with so many strangers and a lot of noise and lack of comfort. Even though I visited her before and after work, the delirium was highly visible. She was frustrated, confused, and kept attempting her daily exercise routine. Her health declined in spite of every good effort. End-stage dementia took over, crippling her physically, mentally, and spiritually. Now, my sister suffered from scoliosis as a young adult. In her later years, she used a CPAP machine for breathing and later on oxygen. She began experiencing delirium, sudden weight loss, not eating, drinking, not sleeping well, and fearful of every sound, even when it was quiet. She felt that way. Frankly, we were both scared at this sudden onset. She was sent to the hospital for tests, which revealed pancreatic cancer, which ended her life within 2 months. Her journey ended while we were having a conversation, just like you and I are having today. She simply stopped talking. 911 arrived, confirmed she had passed on. Right there as we spoke. She took her last breath, and I didn't know because her eyes were still open. And I was wondering why she wasn't talking anymore. It was another grieving 9 months later, both at home. I'm still in recovery from burnout and recovering from the mental health strains of caregiving for both my mom and my sister at home. But it was all pleasure, and I would do it again. Frankly, my sister and I were both scared at the onset of her illness, and that my mom had just recently passed away. And in between my mom, my foot broke. So my mom passed away June 4th, 2016. My foot snapped off on October 27. And I have much metal and screws in my right foot at this time. And I just thought, now what? Mom has passed away. I couldn't walk. And now how can I help my sister? But thankfully, I was able to get assistance with that. So I just want to thank you for the opportunity to share my story, and hope it has encouraged others, and that you can continue on in spite of your struggles. And it's okay to know that you're not alone. OCO is beneficial, especially during these times, the peak of our aging population, caregiver burnout, and so much more personal stories. I did and continue to experience caregiver stress emotionally, mentally, and physically. I joined in to learn self-care and to help myself and others, spreading the OCO good news. I am grateful for the opportunity to be on this panel, to learn from others, and to be there for others. And in closing, I just want to say it makes me more self-aware of end of life and what other people are going through, and to make myself available even if I meet somebody on the street, to be able to care for them. I share with so many of my neighbors that are taking care of elderly parents about the OCO. They log in, hopefully, and they're watching. So I'm spreading the good news about OCO because it has been helpful to me as well. Thank you so much for having me today.
Thank you, Angela. Thank you for joining us and for sharing your story. I know that's not always easy to share, but it does really help people to hear other people's experiences. So thank you for joining us today.
Thank you for having me.
Next, I'd like to introduce you all to Lisa Como. So Lisa is also a caregiver who's joining us to share a little bit more about her experience. Lisa's cared for her mother who manifested several signs and symptoms of delirium across numerous settings. So welcome, Lisa, if you want to unmute and show us your camera, your face. Perfect. There you go.
Thank you very much. I appreciate the opportunity to be here and to participate in this. So again, my name is Lisa Como, and I was a caregiver for my mother for 3 years until she died about 6 months ago. I am a member of the OCO Caregiver Advisory Panel, and that's where I learned about the patient guide and the Delirium Quality Standard developed by Ontario Health. So my mother also had several medical issues in the last few years of her life. She had cancer. She also had a stroke, which didn't leave her paralyzed, but left her with some significant cognitive disabilities. And then finally, she fractured her hip, and that's what ultimately led to her death. Because of all of these things, she also went through a number of major life changes. She needed to leave her home, for instance, and move into a retirement residence where there was a small nursing, personal care staff. She didn't eat well, she didn't drink enough water, and she didn't sleep well either. And what I learned, unfortunately, after the fact, but by reading the patient guide, was that all of these things actually made her vulnerable to delirium. As I said, I didn't know that. I spent a fair bit of time, Google researching and so on, and I bumped into the term delirium a couple of times, but nobody that I dealt with, none of the medical staff ever talked to me about delirium or suggested any resources. And so after looking through the document, it is a really useful document, and I'll speak to that a little bit more at the very end. But I guess just to get into the story, I'll give you a little bit of an overview of some of the experiences that I went through as my mom was having her experiences with delirium. She had several experiences, both at home and in the hospital. And so I want to talk about two of the main symptoms that seemed to recur for her. The first one was physical agitation, very extreme physical agitation. And basically, when this came on, she just could not physically relax. She could not stay in a position for probably more than 30 seconds at a time without needing to move again. And this would go on for hours on end. So it was, exhausting for her, but it was exhausting for me. It was exhausting for the staff who were working with her. So, the first time I saw this was in emergency after she had her stroke. And so she was conscious, and the bed needed to go up and it needed to go down, and put the pillow there and take the pillow away and roll her over. And, and it was just nonstop for hours. In that particular instance, it turned out that pain management was the issue. And once they managed to get that controlled, she was fine and she was able to relax. Another hospital experience that was far more severe this time was after her hip surgery. As I said, it was much worse. This time she was physically trying to get out of the bed to the point that the nursing staff put the bed alarm on, and they actually tried to hire a night sitter just to sit at the end of the bed and watch her. During this episode, she also had hallucinations. She thought that the dark blue flecks in her hospital nightgown were pieces of chocolate, and she was trying to pick them up and eat them. Because this was post-surgical, it was a different situation than the stroke. There was a possibility that, the big cocktail of drugs that she was on may actually have caused those symptoms. So the response at that point was largely diagnostic. They were doing blood tests and urine tests and trying to figure out what it was that caused the symptom before they were able to treat it. So physical agitation was one of the big things. Another thing that happened quite often with mom was cognitive confusion and anxiety. And a lot of that happened because of the damage that she suffered through the stroke. But in one, key example that I want to share, it was clearly a case of delirium. Somebody found her outside in the hallway of her apartment and brought her back into her place. And thankfully, our telephone numbers were available and they called me. The point is, though, that this was really, really uncharacteristic for her. She was not a wanderer. In fact, she never really left her apartment at all. So on that telephone call, she begged me to go and stay with her. And of course I did. And when I got there, she told me, similar to what we heard from Angela, that even though she recognized all her furniture and the cat and, all of these things, she did not think that it was her place. It was her home. She did not know where she was, and she was afraid. And so this confusion set off, yet another bout of physical agitation, and she was up and down and pacing and all the rest of it. So the only thing that I could do at that point was to reassure her that, in fact, she was at home. This was her place. I was with her. She was safe. And, the care staff were coming in. She recognized them. They helped as well, just to sort of reassure her. But in terms of the physical agitation, again, it was several hours of trying, morphine and various other things. Finally, the nurse got some midazolam out of the palliative care kit, and that was what finally put an end to the agitation and allowed her to calm and have some rest. So, I could talk more. I won't. But simply to say that these were really, really stressful experiences. They were terrifying for her. In many cases, very, very uncomfortable for her. And they were really hard on me as a caregiver. I mean, it was physical movement for hours on end, trying to relax her and not having a great deal of success. And as I said at the beginning, not knowing what it was that I was dealing with, not knowing that this had a name. And so, looking back on this and, having been introduced to the Delirium Patient Guide, I recognize that as a caregiver, I really would have benefited from having that information when I was going through it with my mom. I find that the information there is very accessible. It does a very good job of outlining what the possible symptoms are and pointing to some of the underlying issues, like not eating well and not drinking enough. It makes really important distinctions between delirium, dementia, and depression, and it provides useful guidance for caregivers for how to respond, and I think importantly, how to discuss this with the medical team. So I know that in my mom's case, her medical team did everything that they could to diagnose her and treat her and keep her comfortable and lucid and all the rest of it. And I can understand that from their perspective, given all her medical complexities, might not have made a big difference to identify delirium as yet another condition for treatment. But for me, as a caregiver, it really would have been helpful to have that conversation with them and to have a better sense of what it was that I was dealing on the front lines. And I actually think that it would have been useful for some of the nursing staff in the retirement residence to also have a better handle that what they were dealing with was dementia, it was delirium. It wasn't just a dementia that was getting worse. This was something unique and treatable. That's my story. Again, thank you for the opportunity to participate in this webinar today, and I hope that what I've shared is useful for some of you. Thanks very much.
Thank you, Lisa. Thanks so much for taking some time and sharing your story with all of us. You mentioned the not knowing, and hopefully after today's session and hearing all of your stories and the information that's going to be presented, folks will leave with a lot more resources and tools and information to help them navigate their own caregiving journey. Next, I'd like to introduce folks to Kathy Smith, another caregiver who's joining us. Kathy was a caregiver for her husband who experienced delirium while he was in the intensive care unit following cardiac and vascular surgeries with long exposures to anesthesia. So I want to welcome Kathy.
Thank you and good afternoon, everyone. My name is Kathy Smith and I live in Thunder Bay in Northern Ontario, and we often have to travel for any type of specialty health services. I'm a member of the OCO Caregiver Advisory Committee and was one of the ones that helped set up the original website. I thank OCO for this opportunity to share my lived experience with post-surgery delirium with you today, because I think that both Lisa and Angela have already spoken quite clearly about the need for better communication and earlier knowledge of what we're dealing with. And the same applies in my situation. Albert Einstein said, "Strive not to be a success, but rather to be of value." And I hope my story will be of value to you all today as well. Postoperative delirium was not a condition that my husband and I were aware of, nor did we ever anticipate we would run into that situation. We weren't prepared to deal with it prior to his life-threatening cardiovascular surgery. Upon return from ICU, from recovery, I'm really grateful that we had a very helpful ICU nurse in charge. And with her excellent intensive care team, they alerted me to the possibility of post-surgical delirium. His nurse advised me how to recognize some signs of altered mental function immediately post-op. She also gave me some hints for helpful support. Apparently, my husband was a prime candidate, which I didn't know. He was 75, and elderly post-op patients are at higher risk for acute delirium. They don't handle anesthesia very well. His aortobifemoral bypass surgery took 5 unders under general anesthesia. He suffered several bleeding episodes post-op and required many blood transfusion. I lost count after 7 or 8 pints. His blood oxygen level was always at a lowered level for an extended period of time. I knew nothing of these risks for delirium prior to the surgery. That advice I received in ICU came just in the nick of time. My husband was fine for the first 2 days, perfectly lucid. But on the 3rd day, he was talking nonsense. He was hallucinating, thinking that he had an open wound in his stomach and somebody was pouring betadine into it. Not true. My stoic, sensible, scientific husband was off the wall with his thinking, and I could recognize that. And I was glad I had some ideas for supporting. Never had I seen this behavior before, but with the coaching that I got, here's what helped. Support and stay with the patient if possible. Be the patient's familiar landscape and rock. Dwell on the real. Reorient and reassure the patient calmly and let them know what time of day it is, where he is, why, just some of the simple, how the weather is, simple facts that they can absorb and put into perspective in reality. Also, if the person is agitated or hallucinatory, give them some past or upcoming pleasant events to dwell on. The people that you know will be familiar, or familiar pleasant places. At the next medical check-in, I did take action and reported his delusionary conversations to his ICU nurse. I also told her that I noticed he had been switched off of the IV pain medication onto a self-monitoring pain pipe, but he was far too out of it to ever use that. So they switched him back onto the IV pain administration, and reality returned for him almost immediately. He continued to progress over the next 2 days in ICU, and I thought we were going to get over the hump without any more problems with delirium. I didn't know delirium also affected mood and physical behavior. Late on day 5 post-surgery, he was transferred from ICU back onto the cardiac ward. When we went to visit him early that evening, he immediately told us he didn't have the energy and was just too exhausted to even talk. we understood. We felt he was handling things very well, and basically interpreted his docile passivity as a good sign that he was intuitive and able to self-manage his condition. That wasn't really true. However, it turns out that this social withdrawal is another side effect of post-op and brings on post-op delirium, one I didn't know about. Delirium alters the physical and emotional behavior as well as cognitive thinking. And like the March weather, they can be lions or they can be lambs, and it will go back and forth. When my daughter and I arrived at noon the next day, we were totally shocked, even afraid of his aggressive agitation. This man is a pool of patience and a sea of serenity. Never, ever raises his voice. He doesn't even use the cuss words that I could teach him. He's a very calm, quiet person. And yet there he was, very angry and agitated and difficult. Apparently, he had been told he was discharged at 9 o'clock in the morning and had been waiting patiently, quote, quote, for us for 4 hours. We did not receive notification of this discharge and were told it was because our number was long distance. We did not believe him when he told us he was discharged. How could someone on death's doorstep just hours ago in ICU be discharged? And in particular to someone that's living in a VRBO rental house with no supplies, no support system, no doctor, no nothing. That was me. Anyway, we just didn't think it could be true. So while I was out at the nurse's station trying to confirm his discharge, he leaped out of bed, charged past my daughter, headed towards the elevators down the hallway. She couldn't hold on to him. He was so aggressive. With superhuman speed and strength, he streaked down that hallway in an open nightgown, barefoot in November, with his butt flapping in the breeze. There was no wheelchair to be had to help him. It was lunch break for the staff, so there was no one to help us. We had no clothes for him. He was agitated, but also very weak. He was dizzy and staggering against the wall. My daughter propped him up on her shoulder and slung her coat over his shoulders to cover the bare backside. She could not get him to turn back, and her pleas for help were unanswered. I don't blame the staff. I'm just saying it's a very busy ward. They were short-staffed, and this was the best that could be done for us as caregivers. So she carried on to the elevators while I was at the nurse's station, trying to confirm his discharge status with the ward clerk. Yes, he had been discharged, and there was really no instructions other than to follow up when you get home. Well, get home is 2,000 kilometers away and 2 weeks away, and I have nothing in the house to care for this person. I'll get to the solutions in a few minutes. The discharge papers were not signed by a doctor, they were signed by a resident. And the no phone call is it's almost a patient safety issue. There were no discharge instructions other than, as I said, a prescription for a painkiller, an opioid to be filled out at the nearest drugstore. And where that is for somebody from out of town is difficult. I wonder if hospitalists or residents are not as connected to the patients and therefore not as invested in the person-centered care as they should be. This again is another patient safety issue. My husband was definitely in no shape to go home that day. I was in no shape to care for that very sick patient suffering with delirium, and no prior preparation or support system in place to follow up. Pain control was my biggest concern. No pain meds had been given to him since 8 o'clock that morning. He was discharged with a prescription for an opiate pain med. Need I relay the hassles we had getting that filled in a drugstore where no one knew us, 2,000 kilometers from home, by a daughter who lives in USA. It took 3 trips to that drugstore to finally get the pain meds. By that time, my husband finally got them. It was 6 o'clock in the evening, 10 hours of coping with excruciating pain with no medication. Has the pendulum swung perhaps too far in the opioid reluctance direction? I did not know that We needed not only our own identification, our own OHIP card, we also needed the patient's OHIP card. And in the case of my daughter in US, coming from USA, they wouldn't give her the medication at all. So then she had to come back, change places with me, and I had to go and get that. I had seen how elevated levels of pain affected his mental state, so at least I was prepared. And again, those supportive, helpful hints did help. Finally, once medicated for his pain and in a quiet, warm bed at our own B&B home, the peaceful, quiet setting calmed him down and the delirium did dissipate. With natural day and night lighting and his loved ones surrounding him, he really did settle down and was completely back to normal within another day. In retrospect, I would like OCO to make sure surgical patients at risk for delirium and their caregivers are well instructed prior to the surgery so that we are well prepared to recognize and ameliorate delirium, maybe even avoid it. Caregivers need a much more in-depth pre-op preparation to best handle this condition. The information on the delirium fly sheets I have seen are too brief, too generic, and too impractical. Some lived experience stories possibly could help. A caregiver hotline or a patient navigator would really help, particularly for those that have to travel for health services like myself. What we need to know in advance: who is at risk for delirium and why? I didn't think my husband was. What are the common signs and symptoms of delirium? Delirium not only alters the mental state, but it can affect the physical behavior. Didn't know that. Delirium can develop later on, and it can change its face from docile to destructive to back to docile. Opioid prescriptions filled at an out-of-town pharmacy require the OHIP ID of both the patient and the caregiver picking up the prescription. Better still, it would all of this would have been avoided if that prescription had been filled out and ordered by the hospital directly. I wouldn't have had to go through that extra hassle. Where can a novice caregiver go for in-person help, emotional and educational? And I know that both Anita and Lisa have alluded to that too. Better communication and better education. How can caregivers better team up with providers so we all work together for the best for the patient, in particular for the safety of the patient in a discharge? I felt it was a discharge drop-off rather than a transfer over. I was left alone to navigate some very difficult and technical situations. Assign a rapid response nurse to check in when you know the situation. Note on the record that the person is from out of town and the caregiver is from out of town with no supplies, and get a rapid response nurse to at least phone and see if everything is going okay. Also, when traveling out of town, there should be some sort of a waiver. I had to bring that very sick man on the plane, and they would not give us one of the bigger seats because basically we weren't a first class person, even though I explained about the surgical wounds and what have you. I know that's arbitrary, but it should be mandatory that in these conditions that service is provided. If I think I've pretty much come to the end, I found that once I did get home, I was still coping on my own because it took a week to get in to see the doctor. By that time, my husband had been 2 weeks on medication that was too strong for him. It precipitated a readmission, but was that a black mark against the original discharge hospital? I doubt it, and it should have been. And that safety issue should definitely be addressed in the caregiver organization. If my lived experience somehow has helped others and caregivers who are dealing with a similar situation, then the experience we went through served a good purpose, and sharing this journey has had some value. Thank you for the opportunity to share today.
Thank you so much, Kathy, for sharing your experience and providing us with lots of great tips and some really important questions. And I hope that our next speakers will be able to provide some more information for the audience and for all of you that have shared your stories, and maybe answer some of those questions with the information and resources we're going to be sharing. So I'd like to introduce next Deborah Brown. who is a nurse practitioner and a member of the Senior Friendly Strategy, and also Sunnybrook Health Sciences Center's Delirium Quality Standard Advisory Committee, to share some great information around delirium. And I'd also like to introduce Apurva Shadokar, who's our Quality Improvement Specialist at Health Quality Ontario, who's going to be sharing some helpful resources as well.
Thank you, Katie. I want to also, before I begin, thank the caregivers for sharing those wonderful stories for us and helping us to do better in the future and pointing out some really important pieces on this whole aspect of delirium care. So we have to really understand what is delirium. And delirium is a sudden change really in how someone thinks, acts, or understands what's happening to them. They might be confused, see things that aren't there, or seem quiet, withdrawn, or sleepy. They can also be anxious, restless, agitated, or angry. And as we've heard from stories that the caregivers have shared with us, they can fluctuate, patients can fluctuate between these two states on a regular basis. Delirium clinically we consider as an acute disorder of attention, awareness, and altered mental status. It develops over a short period of time, usually hours to a few days, and tends to fluctuate in severity during the course of a day. While there are key clinical features of delirium that we look for as clinicians, the presentation of those features and the nuance can be highly individualized. Therefore, the key piece is really understanding what the person's normal baseline is, and that is where caregivers are so crucial in helping us to understand. Next slide, please. Who's at risk for delirium? We have heard some of the risk factors from our caregiver stories earlier, so I'll go over them quickly. The key risk factors for delirium include being 65 years or older, having a history of cognitive impairment and or dementia. Certainly, a fractured hip is a high risk factor for delirium, and severe illness. And we consider this any kind of a clinical condition that is deteriorating or at risk for deterioration. We can think quickly of things like sepsis, acute pneumonia, heart failure, etc. A lot of these conditions would fall into that category. A history of previous delirium and problematic alcohol or substance abuse. So although delirium may be caused by a single factor, it is much more commonly the result of many factors. We call it multifactorial. We like to think about the causes of delirium really as being an interplay of factors that predispose the person to delirium, things that you come with like your age and your medical history, and exposure to other precipitating factors or stresses like medications, acute illness, constipation, urinary retention, those kinds of things. So it's an interplay between predisposing and precipitating factors. And sadly, up to 30% of cases, we really can't pinpoint an identifiable cause. Next slide, please. And you need to know delirium is very common in older people in the hospital setting, with an overall occurrence rate around 30% to 64%. The prevalence in the community is much lower, but often and appropriately results in an emergency visit. We do consider delirium as an emergency and should be investigated quickly. It has been associated with increased mortality, prolonged hospital length of stay, and increased placement in long-term care homes after hospitalization. And as we've heard from our caregivers who told their stories, delirium can be a stressful and frightening experience for the person and their family and caregivers. And also, I have to point out, for some healthcare providers as well. Next slide, please. So delirium is not always recognized, and it's sometimes misdiagnosed as another disorder and misattributed to dementia. Early identification of risk factors is important because we could start to prevent delirium and can be successful in 30 to 40% of cases. So in general, it's important to note when you're thinking about delirium versus dementia, there are some key differences. In delirium, symptoms show up quickly within hours or days. Symptoms can come and go over the course of a day. In dementia, Typically, your symptoms develop slowly over months and years, and symptoms are usually the same from one day to the next with a general progression. So there's a difference certainly between delirium and dementia. Next slide, please. So now we're going to talk about the delirium quality standard. And quality standards inform patients, clinicians, and organizations about what high quality care looks like for health conditions or processes deemed a priority for quality improvement in Ontario. They are based on evidence, best evidence. The scope of this delirium standard includes care for adults aged 18 years or older who are at risk for delirium or who are experiencing symptoms of delirium. It includes people in hospital in all aspects of the hospital. It includes people transitioning from hospital to home and in long-term care homes and other community settings. The standard focuses on identification, assessment, prevention, and management of delirium across all healthcare professions. However, I want to point out that the standard does not apply to people with confusion related to withdrawal from alcohol. It also excludes guidance on the specific management of health complications secondary to delirium. Next slide, please. The quality standard itself has 7 quality statement topics that all these topics are elaborated on. Today, we're going to focus as much as possible on 3 quality statements. And they are the interventions to prevent delirium, the screening for delirium, and education for people with delirium and their family and caregivers. Thank you. So this statement is part of our standard, and it's interventions to prevent delirium. And I think one of the most important pieces. People at risk for delirium receive interventions to prevent delirium that are tailored to their individual needs and also customized to the care setting. Next slide, please. So there are lots of resources, lots and lots of resources to help you understand what some interventions you can do to help prevent delirium. This slide shows you a couple. The link on the left is from the HELP program, which is a foundational program on delirium prevention. It's very good to access. But I'd also like to point out the wonderful schematic that is resourced through the Regional Geriatric Program of Toronto, displaying 6 principles of prevention care. And we'll take a few minutes fairly quickly to go over those 6 principles. First one is stimulating the mind. And this is really important. This is about promoting daily socialization, reading, listening to music, and any activities that help to remind the patient what day, what month, what year it is, and it helps to support stimulation. When someone is in the hospital, we can try and prevent disorientation by using appropriate lighting and signage, encouraging regular visits from friends and families, and avoid moving the patient from room to room when possible. It's not always possible. Second prevention piece that I think is really key, probably one of the most important pieces, is moving, promoting physical activity. It's crucially important to move as much as possible, whether a person is at home, in the community setting, or in the hospital. Even if you can't walk far, getting out of bed for meals is important. When you're in the hospital, take every opportunity possible to mobilize, even walking from the bed to the wheelchair, or walk from the bed to the stretcher, walk to the bathroom, walk around the ward. Any kind of activity, physical activity, is important. And if patients can't get out of bed, range of motion exercises are also very helpful. Physical activity, minimally 3 times a day. The next one is sleeping well, another key piece in preventing delirium, because delirium can present with sleep-wake cycle reversal, and also can precipitate it. So keeping a sleeping routine, although challenging, especially when patients are in hospital, is key to try to prevent delirium. So we use techniques like meditation, relaxation videos. Music is helpful for some people. Earplugs, eye shields, avoiding caffeinated drinks in the evening. providing a warm decaffeinated drink, warm blankets, anything that helps provide comfort and maintains a sleeping routine, and avoiding excessive sleeping during the day. That's a key piece. The three more quick interventions, seeing and hearing, really important. So the eyes and the ears, hearing aids and glasses need to be available at all times if the patient requires them, or if at home, if the person requires it. And you should be labeled if they're in a hospital for identification purposes. But most institutions have pocket talkers, which are also available as a portable device for amplification. So seeing and hearing, important. Staying hydrated, we've heard about issues of dehydration with our previous caregiver stories, and staying hydrated is crucially important. So plenty of fluids within easy reach and palpable, so they're nice and cool when they need to be cool. Really important. Family can help out with this as well. In the hospital, sometimes we have a sip and go approach, where we say everybody who goes into the room provides a sip of fluid to the patient, and that way we all participate in helping to stay the patient to stay hydrated. Eating and proper nutrition, again, very important, goes along with hydration, and nutritious food is important in promoting eating as much as possible for the socialization benefits with others. Next slide, please. So the next quality statement, talks about early screening. So people presenting to hospital with any risk factors for delirium, or who have an acute change in behavior or cognitive function during a hospital stay, or during a long-term care home, or in the community, are screened for delirium in a timely manner. And this screening needs to be done by a healthcare professional who is trained in screening for delirium using standardized and validated tools. The person and their family and caregivers are always asked, or should always be asked, about any acute changes in the person's behavior or cognitive function. Early screening and detection of delirium is very important, so that reversible causes can be addressed and supportive care can be put in place as soon as possible to manage those symptoms. A delay in identifying delirium symptoms can result in poorer outcomes for patients and significant distress for patients' families and our caregivers. Next slide, please. So the last quality statement we wanted to bring to your attention is about education. And we spoke a lot about education and the importance of education in our caregiver stories. And the quality statement does support that people who are at risk for delirium, or who have delirium, along with their family and caregivers, are offered education. So now we're going to discuss the educational resources that are available to you. Next slide, please. So every quality standard includes a plain language summary for patients, families, caregivers, and the public, called the Patient Conversation Guide. And the patient guide is designed to give patients information about what quality care looks like for various conditions based on best evidence, so they can ask informed questions of their healthcare providers. Next slide. Inside the guide, if you take some time to look inside, you can see that the patient guide provides an overview of delirium, how to recognize signs and symptoms, and information on prevention strategies. As well, how to help treat delirium, and what to know when a person with delirium leaves the hospital, and what you need to know, and some resources you can have. Alongside each quality statement, key questions to ask the care team are included. So it helps empower caregivers and families, as well as links to resources or programs, and reminders to write key pieces of information down along the care journey. This guide can be used by patients and families as well to really facilitate conversations with their healthcare teams that are meaningful for them. Thank you.
Thanks so much, Deborah. I guess I'll invite Apurva to join us now and share a few more resources before we transition to questions from our audience.
I see lots of great comments and questions in the chat, so I won't take too long, but just to continue on from what Deborah has shared, we heard quite a bit about the standard and the patient guide. We have a number of other resources for healthcare professionals and healthcare organizations. interested in adopting some of these principles, we have a concise summary, which is our placemat, as well as measurement and implementation resources. And again, we will share all of these links with you after the webinar. And as well, in terms of caregiving strategies, we developed the quality standard in partnership with the Provincial Geriatrics Leadership Ontario, which is a provincial agency. They have lots of great resources for both caregivers and families, as well as for healthcare professionals working with older adults. And they have a dedicated website for caregiving strategies, which you can see here. There is a handbook as well as online modules. And a number of different topics are included. As you can see here, delirium is covered as well, which is covered under changes in thinking and behavior. And so we encourage you to check out some of these resources and websites, and we'll of course share all of these great resources with you. So yeah, I think I will hand it back to Katie, and hopefully we can have a bit of time for some questions.
Awesome. Thank you so much, Apurva. Those sound like amazing resources. Lots of interest from the chat around whether or not we will be getting that out to people. And yes, so that everyone is aware, we will be sharing these resources and the recording of the webinar today with everyone. So I do want to thank you, Apurva, and Deborah, Health Quality Ontario, and also Angela, Kathy, and Lisa for joining us today to share personal experiences and all of your expertise in the field. I hope that this information will help folks better understand delirium and give people some really great resources to help them navigate this process and navigate through the system.